Hello and welcome back to the deep dive. Today is going to be a little bit different.
A little more intense, perhaps?
A lot more intense. Usually we take a topic and, explore it for the sheer joy of learning.
Maybe to impress friends at a dinner party.
Exactly. But today we are stepping into the arena. I want you to imagine the cold air conditioning of the examination hall, the sweat on your palms, the ticking clock.
And the stern, unreadable look of a senior examiner sitting across the table.
That's the one. We're doing a full, high-stakes, exam-oriented masterclass.
It is a pleasure to be here. And you are absolutely right about the stakes. We are simulating the preparation for a postgraduate MD anesthesiology exam.
And we're tailoring this specifically for those rigorous standards you might find at Gujarat University or similar top-tier boards.
Yes, this isn't just a chat. This is survival training.
Right. And to guide us, you aren't just playing the role of an expert today. You're adopting the persona of that senior faculty member.
That one.
You know, the one who genuinely wants us to pass, but who is going to grill us until we prove we understand the deep physiology, not just, the rote memorization.
I will do my best to be that guide. We are going to strip away the fluff. We are tackling acid-base disorders, but we are doing it by synthesizing the absolute heavyweights of our field.
So we're talking Miller's anesthesia.
Morgan and Mikhail, Guyton and Hall, Harrison's manual, and the very practical ICU protocols.
The Bibles of the trade.
Precisely. If you can synthesize the deep physiology from Guyton with the clinical rigor of Miller and the bedside utility of the ICU protocols, you are not just going to pass.
You're aiming for a distinction.
You're going to secure a distinction. That's the goal.
Okay, so let's set the scene. I'm the resident, you're the professor. I walk into the Viva, and you ask me to introduce acid-base balance.
Yeah.
It seems like such a basic question, but I feel like there's a trap there right at the start.
There is.
Where do I begin to ensure I hit those high marks immediately?
You start with absolute precision. Do not waffle. You define acid-base balance immediately as the regulation of hydrogen ion concentration in the body fluids.
Okay, regulation of hydrogen ion concentration.
But here's the nuance that gets you the extra marks, the distinction level insight. You need to acknowledge the scale.
The scale.
You must remind the examiner that the actual hydrogen ion concentration is infinitesimally small compared to other electrolytes.
How small are we talking? Give us the number.
We are talking about 40 nanomoles per liter. 40.
Nanomoles.
To put that in perspective, compare it to sodium. Sodium concentration is usually what, 140 millimoles per liter?
Right, 140 millimoles.
That is a million-fold difference. 1,000,000 times less concentrated.
That is a staggering gap. So we are regulating a ghost, essentially.
And yet, those 40 nanomoles dictate everything.
Yeah.
They control enzyme function, protein structure, membrane excitability, everything that matters.
So it's a tiny number with a huge impact.
A huge impact. Miller actually has a fantastic phrase you should memorize for your introduction.
I'm ready.
Acid-base abnormalities are robust biomarkers of acute illness.
Robust biomarkers. I like that. It sounds professional. It sounds like I've read the book.
It shows you understand that the pH isn't just a number on a screen. It's a signal of metabolic distress. And for us in anesthesia, it is critical because acidosis changes everything.
How so?
Well, it affects how your drugs work. Think about the ionization of local anesthetics, which determines their efficacy.
Ah, of course. An acidic environment changes how much of the drug is in the active form.
Exactly. It also depresses myocardial contractility. And critically, it causes dangerous electrolyte shifts.
Right, the potassium shift. That's a classic Viva question.
It's a favorite. Acidosis pulls potassium out of cells in exchange for hydrogen ions, so your serum potassium goes up.
Hypercholemia.
If you aren't careful, that dangerous hyperkalemia can be lethal, especially if you are about to administer succinylcholine in an emergency setting. You could cause a cardiac arrest.
Okay, so I've established I know why it matters. Now, looking at the exam structure, what kind of questions am I likely to face?
In a written exam, you're often looking at the classic 20-mark long question.
The big one.
Classify acid-base disorders and discuss their pathophysiology. That is a gift if you are structured, and we will give you that structure today.
Okay, what about short notes?
For short nights, they love asking about the anion gap, the role of the kidney, or base excess, very specific high-yield topics.
And the Viva.
But in the Viva, that is where the real trap lies. They will hand you an AVG slip, usually a complex mixed disorder, and just watch you sweat.
Well, let's make sure I don't sweat. Let's go back to basics. We talked about pH being 7.4, which corresponds to that 40 nanomoles.
Correct.
But I always struggle with converting pH back to actual hydrogen ion concentration in my head without a calculator. Is there a trick?
You don't need a calculator, and pulling one out in Aviva looks weak. ICU Protocols offers a very high-yield rule of thumb for the bedside.
Okay, I need this.
For a pH between 7.2 and 7.50, the hydrogen ion concentration equals 80 minus the last two digits of the pH.
That sounds too simple. Can we walk through an example? Say my patient's pH is 7.35.
Okay. You take the last two digits, which are 35.
35.
80 minus 35 is 45. So at pH 7.35, your hydrogen ion concentration is roughly 45 nanomoles per liter.
That's brilliant.
It's a brilliant, quick way to check if your numbers make sense during an exam or at 3 in the morning in the ICU.
That is incredibly useful. Now let's talk about the defense mechanisms. The body fights to keep that number at 40 nanomoles. We have the lungs and the kidneys.
The lines of defense.
How should I think about them?
Think of them as the fast and slow response teams.
Fast and slow.
The lungs are your immediate response unit. They control volatile acid, which is just carbon dioxide dissolved in water.
So breathing.
Exactly. They can change the pH in minutes just by altering your alveolar ventilation. Breathe faster, blow off CO2, pH goes up. Breathe slower, retain CO2, pH goes down. Simple.
And the kidneys.
The kidneys are the heavy lifters, but they are slow. They take hours to days to fully respond, but they are powerful. They control the fixed acids, and crucially, they regenerate and reabsorb bicarbonate.
So lungs for speed, kidneys for stamina.
An excellent way to put it.
And working between them are the buffer systems. Everyone mentions bicarbonate, obvious.
You must mention bicarbonate. It's the most important extracellular buffer because it is an open system.
An open system, what does that mean in this context?
It means we can get rid of one of its components, the CO2, by exhaling. That makes it incredibly powerful and dynamic compared to a closed system where all the components stay in the body.
I see. But what else should I mention to look smart?
Do not forget hemoglobin. Morgan and Mikhail emphasizes this.
Hemoglobin as a buffer.
Yes, hemoglobin is rich in a specific amino acid, histidine.
Histidine. Why is that specific amino acid important?
The histidine residues have a pKi near physiological pH.
Meaning they're very good at accepting or donating protons right around that 7.4 sweet spot.
Exactly. They are excellent buffers for non-carbonic acids in the blood. And because of the sheer amount of hemoglobin we have, it is actually the most important non-bicarbonate buffer in the vascular space.
That's a specific detail that feels like it would score points.
It will.
Now we have to talk about the Henderson-Hasselbalch equation. I always dread this part. Do I actually need to memorize the formula?
For a postgraduate exam, absolutely. It is the cornerstone of the physiology. You need to be able to write it down without hesitation.
Okay, give it to me.
pH equals 6.1 plus the log of the bicarbonate concentration divided by 0.03 times the PiO2.
Okay, let's break that down. pH equals 6.1 plus log of bicarb over 0.03 times PaO2.
Why 6.1?
That's the pKa of the carbonic acid bicarbonate system. It's a constant.
And the 0.03.
That is the solubility coefficient of CO2. It just converts the partial pressure, which is in millimeters of mercury, into a concentration in millimoles per liter, so the units match up.
Okay, that makes sense.
But conceptually, don't get lost in the math. Just tell the examiner, pH is a ratio.
A ratio of what? It is the ratio of kidney function. The numerator, bicarbonate to lung function. The denominator, CO2.
Kidney over lungs.
If the numerator, bicarb, goes down, the pH goes down. That's metabolic acidosis. If the denominator, CO2, goes up, the pH goes down. That's respiratory acidosis.
It's all about keeping that ratio constant.
It is all about the body's frantic effort to keep that ratio at roughly 20-1.
That makes it much less intimidating. It's just a balance of scales. Okay, let's move to classification. This seems simple. Acidosis, alkalosis, metabolic, respiratory.
Seems simple.
But I feel like there is a terminology trap here regarding anemia versus osis.
There is a massive trap. And falling into it shows a lack of fundamental understanding.
Yeah.
You must distinguish between the process and the result.
Process versus result. Explain.
Acidosis, or alkalosis, is the physiological process that's causing the change. The addition of acid, the loss of bicarb, the retention of CO2.
That's the osis.
Okay. And acidemia, or alkalemia, is the actual state of the blood, the net result. Is the pH actually less than 7.35? That's acidemia. Is it greater than 7.45? That's alkalemia.
So a patient can have a severe metabolic acidosis but not be acidemic.
Precisely. This is a key point. If they have a concurrent respiratory alkalosis, say they are hyperventilating due to pain or sepsis, their pH might be normal.
So if I look at a pH of 7.4 and say this patient has no acid-base disorder, I fail.
You fail. You have to say this patient has a normal pH, but the abnormal bicarbonate and PaCO2 suggest a mixed acid-base disorder. That's the high-level answer.
Got it. Process versus result. Okay, now let's dive into the big one. The one that seems to show up in every ICU case, metabolic acidosis.
The most common and often the most complex.
Definition first.
Primary reduction in bicarbonate, usually below 22 milliequivalents per liter, accompanied by a secondary compensatory hyperventilation to blow off CO2.
And the first thing we do, always, is calculate the anion gap. Miller gives a specific formula for this, doesn't it?
Miller is quite specific, and it varies from text to text, so be careful. The anion gap is the difference between measured cations and anions.
Cations minus anion.
The formula is sodium plus potassium minus the sum of chloride and bicarbonate.
Wait, Miller includes potassium? I feel like I usually leave it out in clinical practice.
Many clinicians do because potassium is a small number and relatively constant. But for this specific exam based on Miller, you should include it. The normal range cited in Miller with potassium is about 4 to 11 milliequivalents per liter.
And if I leave it out?
The range becomes more like 8 to 12. Just clarify which formula you are using to the examiner. Sir, calculating with potassium, the gap is. It shows you're aware of the different conventions.
Okay, that's a good tip. So we have a high anion gap metabolic acidosis, or HHMA. This means we've added an unmeasured acid to the system, right?
Yes. The bicarbonate didn't just disappear. It was used up buffering a new acid. An acid that we don't routinely measure, like lactate or ketones.
And that's where the mnemonics come in. Mud A piles is the old one.
It is, but the modern one you should know is GOLDMARK. It's more current.
GOLDMARK. Walk us through that.
G is for glycols, like ethylene glycol from antifreeze. O for oxaproline from chronic paracetamol use. L for L-lactate from shock. D for D-lactate from short bowel syndrome. M for methanol. A for aspirin. R for renal failure. And K for ketoacidosis.
That's comprehensive. And what if the gap is normal?
If the gap is normal, it means you haven't added an acid, you have lost bicarbonate. We call this normal anion gap metabolic acidosis, or NEET-SS.
Also known as hyperchloremic acidosis. That word always trips people up. Why hyperchloremic?
It's all about maintaining that electrical neutrality we talked about. The body is electrically neutral. If you lose a negative ion bicarbonate from the gut via diarrhea, or the kidneys via renal tubular acidosis.
You've lost a negative charge.
Right, so the kidney has to hold on to something else negative to balance the positive sodium. It holds on to chloride. So bicarb goes down, chloride goes up. The gap between them stays the same.
So simplified, diarrhea equals normal gap, sepsis equals high gap.
As a general rule of thumb, yes, that's a very good way to start.
Now, compensation. The lungs try to fix this by blowing off CO2. Small breathing. How do we know if the compensation is adequate?
Winter's formula.
Yeah.
You cannot walk into an exam without it.
Okay, I'm writing it down.
The expected PaCO2 equals 1.5 times the bicarbonate plus 8, plus or minus 2.
1.5 times bicarb plus 8 plus or minus 2. So let's apply it. If my patient has a bicarbonate of 10...
Okay, 1.5 times 10 is 15, plus 8 is 23. So you expect the PaCO2 to be between 21 and 25.
But what if the actual CO2 on the gas is 40?
Then the patient is failing to compensate. A CO2 of 40 is normal for a healthy person, but for this patient, it represents a severe, life-threatening respiratory acidosis on top of the metabolic one.
So they're tiring out.
They're tiring out, or they have airway obstruction, or they've been given too many narcotics. That is a red flag for intubation.
That is where it gets really interesting clinically. A normal number isn't always normal.
Context is everything.
Let's flip the coin. Metabolic alkalosis. Primary increase in bicarbonate. What causes this?
Usually we lose acid. Vomiting is the classic cause. You lose hydrochloric acid from the stomach, or NG suction. Or diuretics, you lose fluid and concentrate the bicarbonate that's left behind.
And Harrison's manual makes a big deal about chloride here too, right? It's not just for acidosis.
It does. It divides metabolic alkalosis into chloride responsive and chloride resistant. This is a very important clinical distinction.
How do we tell the difference at the bedside?
Check the urine chloride.
The urine. Okay.
If the urine chloride is low, less than 10. It's usually due to volume depletion from vomiting or diuretics. The kidney is avidly holding on to everything, sodium, water, and chloride, to maintain volume.
And we call this chloride responsive
Because if you give them saline sodium chloride, they get better. You replace the volume and the chloride, and the kidney can finally let go of the excess bicarbonate.
And if urine chloride is high, greater than 20,
That's chloride resistant. Now you're thinking about hormonal issues. Mineralocorticoid excess, like Conn syndrome or Cushing's disease or severe hypokalemia. The kidney is being told by hormones to dump acid and chloride. Saline won't fix this. You have to treat the underlying hormonal problem.
I see. And what about compensation? The lungs should hypoventilate to hold on to CO2 to balance the alkali rate.
They try. But there's a limit.
What's the limit?
There is a ceiling, or rather a floor, for ventilation. The body will not stop breathing just to fix the pH. Hypoxia is a stronger drive in pH.
The hypoxic drive.
Yes. Once the PO2 drops too low or the PaSO2 rises too high, the chemoreceptors in the carotid body scream, "Breathe!" And that drive overrides the attempt to compensate.
Yeah.
So you rarely see a PO2 above 55 or 60, solely as compensation for metabolic alkalosis.
Moving on to the respiratory side, respiratory acidosis. This is bread and butter for anesthesia. Opioids, residual neuromuscular blockade, airway obstruction.
Exactly. It's primary hypercapnia, a failure of ventilation. But the key for the exam is distinguishing acute from chronic. This changes your management and your interpretation entirely.
Because the kidney takes time to kick in?
Correct. In acute respiratory acidosis, say a heroin overdose or an acute asthma attack, the kidney hasn't had time to act, so the pH drops significantly. The formula from ICU protocols is, for every 10 millimeter of mercury rise in CO2, the pH drops by 0.08.
That's a steep drop. A CO2 of 60 would give a pH of around 7.24.
Very steep. But in chronic respiratory acidosis, like a COPD patient who lives with a high CO2, the kidney has had days, weeks, even years to retain bicarbonate and buffer the acid.
So their pH is better defended.
Much better. It only drops by 0.03 for every 10 millimeter of mercury rise in CO2.
So a COPD patient with a CO2 of 80 might look surprisingly comfortable and have a pH of 7.28, while an acute asthmatic with the same CO2 would be near death with a pH below 7.1.
Precisely. And knowing that difference saves lives. You don't rush to intubate the COPD patient just based on the number. You look at their baseline.
Okay. What about the flip side? Respiratory alkalosis.
Primary drop in CO2 due to alveolar hyperventilation.
So pain, anxiety, fever.
Sepsis, stroke, pulmonary embolism, or very commonly iatrogenic.
Us. We did it.
We overventilated the patient in the operating room. It's very easy to do.
And clinically, this causes tetany, right? Paresthesias, muscle cramps?
Yes. And it's a great Viva question to ask why. The answer is that alkalosis causes albumin, which is a protein in the blood, to bind calcium more tightly.
So the total calcium is normal, but the active ionized calcium is low.
Exactly. This functional hypocalcemia is what drops the ionized calcium levels, causing neuronal excitability, carpopedal spasm, or tetany. It can look like a seizure, but it's just low calcium availability from the alkalosis.
Okay, we've covered the four corners. Now let's get messy. Mixed disorders. This is the exam favorite, isn't it?
It is the Viva trap, because real critically ill patients rarely read the textbook and stick to one disorder.
They like to keep us on our toes.
Always.
Can you give us a classic scenario where a student might get tripped up?
Absolutely. Take the septic shock patient on a ventilator.
Okay, a common sight in the ICU.
They have high lactate from the shock, so they have a high anion gap metabolic acidosis.
Got it.
But maybe you have the ventilator rate set too high, so you're blowing off too much CO2. Now they also have a respiratory alkalosis.
So one process is pulling the pH down and the other is pulling it up.
Exactly. The pH might look deceptively normal, say 7.40, but the PCO2 is 25 and the bicarb is 15.
So if I just looked at the pH, I'd say they're fine.
And you would be wrong. You would miss two potentially lethal pathologies pulling the pH in opposite directions. Another classic is the vomiting pregnant lady.
Okay, unpack that one.
The vomiting causes a metabolic alkalosis from loss of stomach acid.
Makes sense.
But pregnancy itself causes a physiological respiratory alkalosis. Progesterone is a respiratory stimulant. So pregnant women normally have a slightly lower PaSO2.
So you have a double alkalosis.
Yes, the pH will be dangerously high. You have two processes both driving the pH upwards.
So how do we spot these? What's the clue that there's more than one thing going on?
The clue is usually in the compensation. If the compensation is too good or not enough, meaning it doesn't fit Winter's formula or the other compensation rules, there is a second disorder.
So if the CO2 is much lower than what Winter's formula predicts.
Then there's a primary respiratory alkalosis on top of the metabolic acidosis. And if the pH is normal, but the CO2 and bicarb are both wildly abnormal, it is almost certainly a mixed disorder.
That leads us perfectly into the systematic approach. If I'm handed that terrifying ABG slip in Aviva, what are my steps? I know ICU Protocols outlines a great method.
Be robotic. Don't panic and don't try to intuit it. Follow the steps.
No.
Step 1. Check the pH. Is it acidemia below 7.35 or alkalemia above 7.45? This tells you the primary direction of the disturbance.
Okay, step 2.
Step 2. Check the PaHo2. Is it a respiratory problem? Does the CO2 explain the pH? If the pH is low and CO2 is high, the primary problem is a respiratory acidosis.
Simple enough. Step 3.
Step 3. Check the bicarbonate. Is it a metabolic problem? If the pH is low and the bicarb is low, the primary problem is a metabolic acidosis.
Okay, so now I have my primary disorder. What's next?
Step 4. Check for compensation. This is where you use the formulas. Is the body responding appropriately? Is the CO2 what you expect for that level of bicarbonate based on Winter's formula?
And finally, the anion gap.
Step 5. Calculate the anion gap. You must do this for every metabolic acidosis to find the cause.
And there is a step 6, right, for the advanced students, the distinction level students.
The delta ratio, or sometimes called the gap.
It sounds like high-yield territory.
It is. It's the ratio of the change in the anion gap to the change in bicarbonate.
The change from normal, you mean?
Yes. So the increase in the anion gap divided by the decrease in bicarbonate. Conceptually, for every 1 unit the anion gap goes up, the bicarb should be used up by 1 unit. So the ratio should be close to 1 to 1.
Okay, a 1-to-1 relationship. So what if the ratio is less than 1, say 0.5?
It means the bicarb has dropped more than the gap has risen. That implies there's a hidden normal anion gap acidosis like from diarrhea occurring on top of the high gap acidosis.
Yeah.
There are 2 reasons to be acidotic.
Wow, and if the ratio is high, like greater than 2?
It means the bicarb hasn't dropped enough for how high the gap is. There must be a hidden metabolic alkalosis propping the bicarb up.
And this is classic.
In DKA patients who have been vomiting, they have ketones driving the gap up, but the vomiting is keeping the bicarb artificially high. The delta ratio unmasks that hidden alkalosis.
That is seriously high-yield analysis. Okay, let's run through some quick clinical scenarios to tie this all together. We touched on sepsis.
Sepsis is lactic acidosis, high anion gap. It reflects tissue hypoxia. And remember, the treatment is restoring perfusion fluids, pressors, not just giving bicarb.
Right, treat the cause.
Yeah.
Diabetic ketoacidosis.
Ketones accumulate. A classic high anion gap acidosis, as we just said, often mixed with metabolic alkalosis from vomiting. Remember, fluids and insulin are the cure. The bicarb will fix itself.
What about renal failure?
In renal failure, the kidneys can't excrete the fixed acids that come from protein metabolism, things like sulfates and phosphates. So you get a high anion gap acidosis.
That's in COPD. We mentioned this.
Yes, chronic respiratory acidosis. So you expect a high bicarbonate because of renal compensation. Here's a Viva trap. If a known COPD patient has a normal bicarbonate on their ABG, that's not good.
Why not?
It means something is wrong. They should have a high bicarb. A normal bicarb implies they have a superimposed metabolic acidosis that's dragging it down. Maybe they're septic.
And lastly, let's talk about the post-operative patient. We see this all the time.
It's a minefield of mixed disorders. Shivering increases CO2 production, causing respiratory acidosis. Opioids cause hypoventilation, also respiratory acidosis.
And don't forget the fluids. We pump them full of normal saline.
And 0.9% normal saline is not normal. That is 154 millimoles of chloride per liter. Plasma has around 100.
You're giving a huge chloride load.
A massive chloride load causing a hyperchloremic metabolic acidosis, sometimes called a dilutional acidosis.
Which is why many anesthetists now prefer
Balanced salt solutions like Hartmann's or Plasmolite, they have a more physiological chloride concentration.
Which brings us to management, the golden rule.
Treat the underlying cause. It's the most important principle. You cannot fix a respiratory acidosis with a drug. You fix it with ventilation. You cannot fix DKA with bicarb. You fix it with insulin and fluids.
Speaking of bicarbonate therapy, Miller seems pretty cautious about it. It's controversial.
It is highly controversial.
Okay.
For good reason. The concept is this. Bicarbonate plus acid gives you CO2 and water. If you give IV bicarb, you generate a huge amount of CO2.
And if the patient can't get rid of that CO2, if they're on a ventilator with stiff lungs,
Then that CO2 accumulates,
Yeah.
and CO2 diffuses across cell membranes almost instantly. Bicarbonate does not.
so what happens?
The CO2 rushes into the cells, into the brain, into the heart muscle, and causes a paradoxical intracellular acidosis even if the blood pH on the monitor looks a little better.
That's a sobering thought. You're making the cells sicker while making the lab sheet look prettier.
That is the great danger. Miller suggests reserving bicarbonate therapy only for severe, life-threatening acidemia, say at pH less than 7.1, or in cases where there is actual bicarbonate loss, like severe diarrhea. Don't use it blindly for lactic acidosis.
Okay, we are nearing the end of our session. Let's talk about the exam presentation. If I'm writing a theory paper, diagrams matter.
Absolutely. You need to visualize the data for the examiner, draw the classification table, a simple 4-quadrant box showing the directional arrows for pH, CO2, and bicarb for each of the 4 primary disorders. Draw the flow chart for your ABG analysis. Show your systematic approach. And if you want to really impress, mention the Davenport diagram from Guyton.
The Davenport diagram, that plots bicarb against pH, right?
Yes, and it shows the buffer lines for respiratory and metabolic changes. Even a rough sketch shows you understand the relationship between the respiratory and metabolic vectors. It proves you aren't just memorizing lists.
That's a great tip for the written paper. And for the Viva, what are the common traps or mistakes students make under pressure?
We mentioned the normal pH trap. Never assume a normal pH means no disorder.
Right.
Another one is looking at the numbers in isolation. You must look at the clinical picture. If the ABG says severe respiratory alkalosis, but the patient is apneic from a drug overdose, well, you have mixed up the samples or the machine is broken. Trust the patient, not the paper.
And the normal anion gap in diarrhea question, I feel like that comes up a lot.
Why is the gap normal? The answer is hyperchloremia. You say, sir, the kidney retains chloride to replace the lost bicarbonate, thereby maintaining electroneutrality.
Examiner-approved answer right there.
And one last thing. If they get advanced and ask you about Stewart's approach.
The strong ion difference. I've heard of it, but it seems very complex.
It is. Don't get bogged down unless you're very confident. The safe answer is to mention it exists. Miller chapter 44 covers it. You say that it explains acid base based on the strong ion difference, total weak acids, and PCO2. Acknowledge that it's physically more accurate,
Yeah.
but that for standard clinical interpretation in an exam setting, you are using the Henderson-Hasselbalch approach unless prompted otherwise. It shows you're aware of the deeper theory without getting yourself into trouble.
Stick to what works and what you can defend.
Exactly.
All right, let's wrap this up with a high-yield summary. If our listener takes away 5 key things from this session to write on their hand before the exam, what should they be?
1. pH is on a log scale. Small changes mean big physiological shifts.
Okay. 2.
The CO2 bicarb sister is your main buffer, regulated by lungs, which are fast, and kidneys, which are slow. 3. Always calculate the anion gap in a metabolic acidosis. It tells you the etiology. 4. Check for compensation. If it doesn't fit the formula, it's a mixed disorder. That's your biggest clue.
And 5.
And number 5, treat the patient, not the number. Fix the perfusion, fix the ventilation, or fix the underlying metabolic problem. The numbers will follow.
And a concluding sentence for that 20-mark answer. A nice, neat bow to tie it all up.
In conclusion, acid-base homeostasis is vital for enzymatic and physiologic function. Accurate interpretation requires a systematic integration of history, clinical signs, and blood gas analysis, distinguishing primary from mixed disorders to guide appropriate etiology-based management.
Mic drop. That is fantastic. I feel more prepared already.
Good luck to everyone sitting the exams. Just breathe. Check the pH first, and don't let the mixed disorders panic you. You have a system now.
And for our listeners, your homework is to open Miller chapter 44 and actually draw those nomograms and the Davenport diagram. It sticks in your brain better if you draw it yourself.
An excellent suggestion.
Thanks for joining us on this very deep dive. We'll see you next time.